Hello everyone. In the series of fibroid lectures, today I am here with the uterine fibroid investigations and management. It is mostly the concluding part of our fibroid uterus. Today we will be talking about those patients those investigations which are specific for fibroid uterus. These are not the investigations for AUB. So, when we will be discussing the case scenarios, then we will be talking how to approach a patient with AUB and then come down to a diagnosis of a fibroid. But today we are talking only about those investigations which are like gold standard for fibroid uterus. Starting with the main investigation, which is the ultrasound and the color Doppler, TVS. What do we understand by TVS? Transvaginal sonography. The sonogram that we perform from the vaginal root is known as TVS, and it is very important for the initial and sometimes the final diagnosis of the patient. It is a useful diagnostic tool to confirm the diagnosis. Sonography is a relatively cheaper investigation. It is not invasive. It is available in mostly all the centers, and it is that confirmatory that if a sonography is saying it is a fibroid, in 99% cases it is a fibroid. Transvaginal ultrasound can accurately assess the myoma. What all? Location. For example, this is the uterus and there is a myoma. The sonography will tell you where is it located, what is the size, how many are there, or there are some other adnexal pathology also, whether it is associated with some other ovarian problem or a fallopian tube problem or not. So, mostly the fibroid mapping thing is done with a sonography only. The classification that we have studied that helps us plan the surgery of the patient, it can be done on the basis of sonography. Other findings like sonography is a complete abdomen sonography. So, if there is a big mass in the uterus, we can find that whether it is associated with any other kidney problem or not. So, hydroureteric changes, hydronephrotic changes can be diagnosed. Nowadays, in earlier days it was only a 2D sonography, that X and Y axis were there, but now there are 3D sonographies. We can rotate and can see what is the extent of the mass, what is the location, and everything can be done very nicely on the basis of a sonography. See, this is a picture. How to understand a sonography clip, that is very important. In your exams you may get a sonography film and then you may be asked about the question. So, you should know how to see a fibroid in a sonography film. See, this is a sonography plate. Here very clearly you can delineate the margins of the uterus, right? This is where your probe is, and from there you are studying the organ. And it is all about the echoes. So, it is a smudge like echo. The normal myometrium is a simple smudge like echo, whereas depending on the smooth muscle or the connective tissue, the whole fibroid is either hyperechoic or hypoechoic, and but it is like in the pseudo capsule you can see a specific mass with whorled appearance. So, a firm tumor with a whorled appearance is the hallmark of fibroid, and whenever you study a film, you can see round ball like structures which are either darker or lesser, hyperechoic or hypoechoic as compared to the normal myometrium. So, here you can see that in the center of the organ there is a fibroid, and during the sonography film you can actually measure the size of the fibroid. Second thing, saline infusion sonography. What do we understand from that? That's why I have kept this picture over here. This is a section of a patient where you are looking from the side of the patient. This is the urinary bladder. This is the symphysis pubis, the vaginal canal, and the anal canal and the rectum downwards. So, this is the anterior. This is the posterior. Now, the cut section of the uterus, say there is a submucous fibroid over here, or there is a polyp over here. So if your uterus is not inflated and the endometrial cavity, the anterior and posterior wall are in contact with each other, every mass will look the same. The problem is that vaginal canal and the uterine cavity are potential cavities. They are not cavities on their own. You have to distend it with some medium to see the anterior and posterior wall separately. Otherwise, they are stuck with each other. So if there is some mass in the center of the cavity, you don't know from where it is arising, what it is and what's going on. So they have devised one thing, saline infusion sonography. It is a sonography only, but what we do, we put a catheter from the vagina inside the uterine cavity and start instilling saline, normal saline inside. So it distends the cavity. Now you can see that this is the anterior wall, this is the posterior wall. Whether it is a polyp or a myoma, it is arising from the anterior part or the posterior part and the extent of adhesion with the wall. It is a very, very important tool to differentiate between a submucous fibroid or endometrial polyp or any other foreign body which is lying inside the cavity of the uterus. So for studying the cavity of the uterus, saline infusion sonography is better than simple sonography. We have put, this is a transvaginal sonography probe. So the probe goes inside the vagina. We do the similar thing in transvaginal sonography, but there is a catheter also which is instilling saline inside, so we can view the cavity properly. So it is helpful to detect any submucous fibroid or a polyp. So if a question arises that what is a better investigation to see things inside the endometrial cavity, then the answer should be saline infusion sonography. But the prime investigation, the primary investigation and sometimes the only investigation for fibroid is a sonography, a simple sonography, whether 2D, 3D, and TVS is always better than TAS. Transvaginal scan is much better than transabdominal scan to delineate the size of the uterus. Now the role of hysteroscopy. What do we understand by hysteroscopy? See, it is very easy to know what does the word mean. Hystera means uterus and scopy means to visualize. So anything, any fiber optic telescope which is visualizing the uterus from inside is known as hysteroscopy. So this is the uterus. We enter from the vaginal canal into the cervical canal into the endometrial cavity to have a look on our own. These are fibro optic scopes just like laparoscopes which are put inside the uterus and we can see the walls of the uterus, the ostia, everything. So we get a look and we can decide that whether this is a polyp or a fibroid and we can treat the pathology at the same time. So any submucous fibroid, unexplained infertility, the patient is having infertility and on all investigations you don't know what's going on. Just put a scope inside the uterus and see on your own. Repeated pregnancy wastage. Sometimes there are Mullerian anomalies. We will be talking about it in later classes, that some Mullerian anomalies which are generally not detected on sonography can be detected on hysteroscopy. But in cases of fibroid, if there is some small fibroid or a polyp which is not been detected on USG somehow, we can detect it on hysteroscopy and treat it in the same sitting. This is a view of hysteroscopy. How are we viewing? We are sitting at the vaginal end of the patient and viewing the endometrial cavity from inside. So we are entering the endometrial cavity from the cervical canal. So this portion which is dark, it is the fundus of the uterus visualized from inside and you can see this round structure, right? This is a submucous myoma. It is very different from the normal endometrium. It is lying on the top of the posterior wall of the endometrial cavity. This steel loop or steel hook, right, is a resectoscope. We have put it inside and then we will shave this myoma off. So we are diagnosing in hysteroscopy, we are treating in hysteroscopy. These were the main investigations. Other investigations which do have some role, but it is not mandatory to do all the investigations in all the cases. These are the list of investigations, but these are patient tailored investigations. That is, your patient needs which investigation and in how minimal investigations you can reach to a diagnosis. HSG. What is HSG? Hysterosalpingography. Hystero means uterus, salpingo means fallopian tubes. So what we are doing, we are instilling a dye from the cervical canal inside the uterus, and the dye fills the complete uterus and it then goes in both the fallopian tubes and it gets out from the fimbrial end into the peritoneal cavity. So it's a regurgitation basically of the dye. We are putting it from the cervical canal, the whole of the uterus gets filled first and then the fallopian tubes and then the spillage in the peritoneal cavity. And these are radio opaque dyes. And when we take X-rays, so in X-ray what you will see is a uterine cavity completely delineated with the dye and the fallopian tubes and the spillage inside the peritoneal cavity. So it is a helpful investigation for infertility patients also. It looks at the contour of the uterus, whether there is any filling defect. What do we understand by filling defect? In the uterine cavity, if there is some mass, for example, there is some polyp or there is some fibroid or the cavity is a septate one, so the contour of the uterus will get changed. If there is some submucous fibroid here, so in your X-ray, you will see the cavity like this. So what is this? This could be a mass. It can also check your tubal blockage or not. So in cases of unexplained infertility, HSG is a good investigation. You can see any filling defect in the uterus or any block in the fallopian tubes. MRI, magnetic resonance imaging. Nowadays, MRI is much more accurate as compared to ultrasound. If you want to actually map the fibroid or you want to differentiate between an ovarian tumor or a fibroid, for example, your fibroid is lying just at the level of the cornu. So you don't know whether it is ovary or a fibroid. It looks like a tumor. Either it could be from ovary or it could be from the cornual portion of the uterus. So MRI is a better investigation. It properly delineates everything, but it is a costly investigation. So we can differentiate between adenomyosis and fibroids also, but the problem is that it is 10 times more costlier as compared to the sonography. So we cannot apply MRI in every case, but yes, if you are in confusion, then you have MRI in hand. After sonography you can proceed with MRI. Laparoscopy. What is laparoscopy? To visualize the abdomen from inside. If the uterine size is less than 12 weeks and there is pelvic pain or infertility, laparoscopy per se has less role in diagnosis of fibroids, because generally in all radiological investigations it is clearly seen. But with fibroid, if the patient is having pain, intolerable pain, or there is infertility and you want to rule out endometriosis or any other pelvic pathology, then you can always put a laparoscope inside the abdomen of the patient and see the associated pathologies. Uterine curettage. In present scenario, uterine curettage has hardly any role, because you cannot curette out the fibroid per se and check in your microscope. But yes, if the patient is having unexplained infertility or you want to rule out any other endometrial coexisting pathology, that yes, there is a fibroid, but is the endometrium normal? For example, you are planning for a surgery of myomectomy. That means you want to remove the fibroid only. Then you want to be sure that you are not leaving any other pathology inside the uterus. In that cases, you can go for a uterine curettage. See, if the patient is having irregular bleeding, so to detect any other coexisting pathology. So the take home message is, generally ultrasound and TVS is the investigation of choice. But if it is not giving you the answer, or the mass is just in the center of the uterus, then you proceed with saline infusion sonographies, hysteroscopy, HSG. These are the further investigations, and MRI, which will help you out to find out fibroid. Most of the fibroids are located after these investigations. Now the management protocol. This chart is very important in your exams from all point of views, for answering your theory papers, for appearing for the practical examinations in both UG and PG, both. So we will study this chart in detail because it is the management protocol, that which management to apply in which patient. We will study all the management, but which patient is a candidate of which treatment. So the fibroid uterus, first of all, after sonography or your clinical examination, you decide that whether it is a corporeal or a body fibroid or a cervical fibroid, right? Cervical fibroids are mostly diagnosed on a clinical examination only. So once you reach to a diagnosis, then we will further go for the flow chart. Cervical fibroids are relatively easier to decide the treatment. They are not easier to treat, but the treatment line can be decided in a better way. Either it could be a supravaginal or a vaginal. We know that what is a cervical fibroid. So a fibroid, this is vaginal, but this is supravaginal. So if it is supravaginal, that means at this place. So you will have to approach this fibroid from the peritoneal cavity. You cannot go from a vaginal approach. So supravaginal, either myomectomy. What do we mean by myomectomy? Myomectomy, removal of the myoma or the fibroid. And if the patient wants the removal of the uterus per se, so hysterectomy. We have to give both the options to our patient depending on the reproductive cycle of the patient, the number of kids they want, the age of the patient. We decide that whether to go for myomectomy or hysterectomy. So a supravaginal thing has to be dealt with peritoneal approach, and it could be either myomectomy or hysterectomy. But if it is a vaginal one, that you can have a vaginal approach, you can either perform a myomectomy, just cut it off from this place, or if it is a polyp itself, then it is easier, go for a polypectomy, right? Just pull it out. Now comes the body fibroid. Now fibroids, as I told, 75% of them are asymptomatic, like the patient has come because of some other complaint. You got a sonography done and then you locate a fibroid. So whether to treat that fibroid, it is a question because there was no symptom. So a body fibroid can be symptomatic or asymptomatic. If the patient had come with a complaint of fibroid, either bleeding, dysmenorrhea, abdominal enlargement, abdominal pain, all the symptoms, but we have a checklist, then there are two options. Either we go for a medical management, medicines, but medicines are not the definitive treatment. We will be studying, but you have to give the option to the patient that whether you want to go for a medical management or a surgical management, which is a definitive treatment. Types of surgeries available depending on the patient's age and choice of the patient. Either you can go for a myomectomy or a hysterectomy or a myolysis. This is something new. You can lyse the cells of the myoma with the help of either electrocautery, laser or cryo, right? These are all modalities. They require multiple sittings by which we want to just lyse the cells of the myoma. And embolotherapy, we will be talking about everything in detail, but these are all the options of the surgical management that we can try. Myomectomy can be performed from endoscopic route or laparotomies. Laparotomies means cutting open the abdomen, putting an incision. It is a tomy. What do we understand by tomy? Tomy means opening something and then repairing it back. And ectomy. Ectomy means permanently removing a thing. For example, hysterectomy, salpingectomy, myomectomy. We are completely removing that thing. So laparo means abdomen and tomy means opening up and then stitching it back. So you can remove the myoma either completely opening or the endoscopic approach, which could be laparoscopic or hysteroscopic depending on the location and size of the fibroid. So these are all the surgical modalities available. If the patient was symptomatic, then if it falls in the category of medical management, go with that. Otherwise, surgery is the definitive treatment. Now comes what to do with these asymptomatic people. The patient will ask you, ma'am, I have got a fibroid. What will happen to me? Then we will have to answer. Every 6 months regular supervision, every 6 months you have to go for a sonography and check the fibroid. What in cases of fibroids where the uterine size is less than 12 weeks of a pregnant uterine size. In gynecology, the uterine size is talked about the pregnant uterine size. A 12 weeks pregnancy fills the pelvic cavity completely. So if your fibroid is less than 12 weeks pregnant uterine size, and you are certain of your diagnosis before going for any treatment, you need to be certain about your diagnosis that yes, I am dealing with this patient. So if you know that it is a fibroid and the size is less, then you don't do anything. Just wait and watch. Every 6 months you get a scan done to see for any other changes that are happening in that fibroid. If with time either the size increases or the symptoms start appearing, then proceed for surgery. If the size remains the same and the patient remains symptomless, then keep on following up the patient and wait for the menopause to come. But if initially the size was more, you were not certain about your diagnosis, or the patient was having infertility, there were chances of miscarriage, the patient wanted to conceive, and it was a pedunculated fibroid. A pedunculated fibroid can cause problem anytime. If it is inside the abdomen, it can got twisted, it can become a parasitic fibroid, or it is coming out from the cervix, then it may become infected, necrosed, and other changes of the fibroid. So these are the 4 indications that even if your patient is asymptomatic, go for a surgery, remove that fibroid. If you remember this chart, then half of your job is done. Now medical treatment. When will you offer medical treatment to the patient? Because medical treatment is not definitive. It will just buy you some time. Buy some time to the patient to proceed for the final surgical treatment. So what are the objectives? Why do we go for medical treatment then? If it is a young woman desirous of pregnancy, she is having only dysmenorrhea, she wants pregnancy, and there is a small fibroid. So go for painkillers, wait and watch and let her become pregnant. To improve the menorrhagia, menorrhagia means heavy bleeding PV, and to correct the anemia before surgery. Most of the patients, if they are symptomatic, they will present with heavy bleeding PV in 35% of the cases. Rest of them will be having dysmenorrhea. Because they are having heavy bleeding PV every cycle, so they are anemic. You cannot operate on such patients. So instead of going for blood transfusion, which is a procedure in itself, let's give them hematinics. So we buy time, 2 months, 3 months, stop the bleeding and give hematinics, let the patient be ready for the surgery. To minimize the size and vascularity of the tumor in order to facilitate surgery, mainly your GnRH agonist. What do? The proliferative myomas, the big myomas. If you are going for a laparoscopic myomectomy, it is difficult to remove this size tumor. What will you do? You give GnRH agonist. GnRH agonist will create a less estrogenic environment in the body. The size decreases, the vascularity decreases, and now your patient is easily operable. But in GnRH agonist, the plane of cleavage is lost due to this treatment. So it is the pros and cons, you have to monitor what you want. You want the size to be less or the planes to be preserved. In selected cases of infertility, definitely what I told you, for laparoscopic or hysteroscopic surgeries, for keyhole surgeries, where we want a definite mass with preserved planes. As an alternative to surgery in perimenopausal women or with high risk factors, there are times like there is a 3-4 centimeter fibroid causing minimal problems and the patient is around 48 years of age. What to do? Give medical management for 2 to 3 years, let the bleeding be less and let the time pass. We are waiting for the menopause. If the lady gets menopause, there is less estrogen and the fibroid will start having atrophy on its own. So in perimenopausal woman, we wait for the menopause, and in patients which are high risk from anesthesia point of view that the surgery may be hazardous for the life of the patient, then in those cases we are going with the medical management. Postponement of surgery, the patient wants that because of my family conditions, because of my some other problem circumstances, I am not able to undergo surgery right now, please give me some time. So in short, if the patient wants some time or the doctor wants some time to improve the condition of the patient, we are going for the medical treatment, otherwise not. Medical treatment has no role as such in the treatment of fibroid, but it is just to postpone the thing. Either we are waiting for a pregnancy or a menopause or a generalized improved condition of the patient for a surgery. Now, what are the drugs in our basket which we can use, and we should use them judicially to the patient? Drugs to minimize the blood loss. Our main motto is to minimize the blood loss. RU486 or antiprogesterones or Mifepristone, which we read it also for the MTP kits, Mifepristone. Antigonadotropins, namely Danazol and gestrinone. GnRH analogues, it could be agonist or antagonist. Agonist means pro, antagonist means against. LNG-IUS, levonorgestrel releasing intrauterine systems, or the other name, the marketing name is Mirena. Combined oral contraceptives, estrogen and progesterone combinations, prostaglandin synthetase inhibitors, Melior NSAIDs, and SPRMs, selective progesterone receptor modulators. These are all the bouquet of drugs that you are having. Select the right drug for the right patient. Now, how will you select? Mifepristone is an anti-progesterone. What does that mean? The progesterone receptor, it will bind to the progesterone receptor and it would not allow the progesterone to work. So it will start shrinking the tumor because it is a hormone dependent tumor. It is very effective to reduce the fibroid size. Since the progesterone is not acting, it may also produce amenorrhea till the time the patient is taking the medicine. The moment the patient will stop taking the medicine, after a few days or a couple of weeks, it will start bleeding again. It reduces the size of the fibroid significantly. A daily dose of 5 to 10 milligram is recommended and is found to be effective to reduce the size to 50%. But we cannot give a long-term therapy. Why? Because it is an anti-progesterone. So unopposed estrogen will cause endometrial hyperplasia. So only for a few months, get your patient ready for surgery, give it to buy time, and after a few months, take her up for surgery. Selective progesterone receptor modulator, ulipristal acetate, the only drug marketed. It is a selective progesterone receptor modulator. What does that mean? Progesterone receptors, it resembles progesterone in its structure, so it will modulate those receptors. Blood loss is reduced by 90% and heavy bleeding is reduced. It can be used for 3 months only because the safety profile is still unknown. We are still not using it on a large scale. The endometrial safety we don't know because some benign changes can be noticed in the endometrium on a long-term use. So we don't want to land up in other problem, endometrial hyperplasia or carcinomas. So these all drugs will give you 2 to 3 months to manage your patient. Now comes LNG-IUS. It is a beautiful system. It is a intrauterine device, Mirena. It is a device loaded with levonorgestrel, which releases levonorgestrel, which is a potent progesterone inside the uterine cavity on a per day basis regularly. So what does that do? It reduces the blood loss and the uterine size. But since it is an intrauterine system, it is there for a normal size uterus, or your fibroid is away from the endometrial cavity. So it can manage a normal size uterus or a normal endometrial cavity which is not distorted by the fibroid. So the role of your TVS comes, you locate where is your fibroid, is it near your endometrium, is your endometrial cavity distorted. If the uterine size is more than 12 weeks or there is distortion of uterine cavity, you cannot use this system. You cannot insert it in a big uterus so that it gets lost inside the uterus. Now comes Danazol. Earlier people were using, nowadays it is not a very good drug to use. It is Antigonadotropin. Antigonadotropin, what does that mean? It decreases the hormones in the body. And androgen agonist, this is the main problem. It decreases estrogen, progesterone, that is fine, but it causes a hyperandrogenic environment. So because of the side effects that the patient starts having, androgenic, hair growth, change in the voice, so it is just not, the patient is not compliant with the drug. And if we are using, we can use for only 3 to 6 months. In general, if you don't remember, we don't use any medical therapy for more than 3 to 6 months. Now comes GnRH agonist. What do we understand by GnRH? If we remember, this was hypothalamus, this was pituitary, and this was ovary. So from here, GnRH, gonadotropin, releasing hormone from hypothalamus, goes to pituitary, and from there gonadotropins, that is FSH, LH, go to ovary, and then ovary will secrete estrogen and progesterone, right? So if we act here directly, then there is no estrogen or progesterone. So the options are agonist, that means they look like GnRH. So initially they cause a flare up. They look like GnRH, they act like GnRH. Goserelin, leuprolin, bosarelin, you have depot injections working for 1 month altogether. So these drugs initially they give you a flare up, the symptoms will flare up, but then because of the sustained rise of GnRH in the body, the negative feedback loop starts, and then there is a persistent loss of GnRH and there is no estrogen or progesterone in the body. Is sustained pituitary down regulation. If you remember this word, sustained pituitary down regulation, your job is done. So suppression of ovarian function. Optimal duration is again 3 months. Why? Because it will create a pseudo menopause like situation. There is no estrogen in the body, so there is the calcium metabolism is deranged, right? And the changes of osteoporosis start coming. So you need to add back therapy. Add back therapy, if you are using GnRH for more than 3 to 6 months, then you have to add low dose estrogens or bisphosphonate for the patient for the calcium metabolism to be stable. GnRH antagonist, anta, against. So these are what? Centrorelix, GnRH. And since they are antagonizing, they are against the natural GnRH, so they will give you immediate suppression of the pituitary and the ovaries, and there is no initial stimulatory effect. But benefits are the same. Onset of amenorrhea is rapid, but cost is a problem, and definitely we cannot use it for more than 3 to 6 months. Now prostaglandin synthesis inhibitors, mostly in young patient where the main problem is pain and they want to conceive and the bleeding is heavy but not that much. So we go for naproxen, mefenamic acid. They are simple non-steroidal anti-inflammatory drugs and they will reduce the prostaglandins in the body, and the main thing is relieve pain either due to the endometriosis or degeneration of the fibroid. There is no much change in the amount of bleeding. So mainly in cases of young patients, the main complaint is dysmenorrhea, then they work beautifully well. Other drugs which are available in the market and they work for lesser severity of symptoms are tranexamic acid. It is a anti-fibrinolytic agent. So there is a significant decrease in the blood loss. Antifibrinolytic agent, it acts on the coagulation pathway and decreases the amount of the bleeding. Then aromatase inhibitors. Aromatase, as we know what is aromatase, aromatase is that enzyme which acts on the substrate of estrogen and it decreases the formation of estrogen in the body, as fibroid is a estrogen dependent tumor. So when aromatase is inhibited, it helps. So the main example are anastrozole, letrozole. We generally add them in the luteal phase. We want to decrease the final product, that is the estrogen. So aromatase inhibitors have been tried and tranexamic acid decreases the blood loss. There are combination drugs available in the market of tranexamic acid and mefenamic acid, which are generally used for young patients having dysmenorrhea, heavy bleeding PV. What are the second line therapies? This was, so we complete our medical management here. We talked about the indication. We talked that it is not the definitive management. We are just buying time. Now second line, your patient does not want to go for a medical therapy. They don't want a definitive surgical treatment. Then we have the option to decrease the size of the fibroid by modalities like magnetic resonance guided focused ultrasound. What does this mean? So there is a machine. The patient lies down. It is just like your CT machine or MRI machine. And the MRI guided, this is the fibroid inside the uterus. And then we focus the ultrasound rays to cause myolysis and to decrease the size of the fibroid. It requires multiple sittings. So focused high energy ultrasound waves induce coagulative necrosis in the myomas. So it causes a localized thermal ablation of the fibroid tissue and it needs multiple treatments. Multiple times patient may need that focused ultrasound and then the size of the fibroid starts decreasing. But the contraindications are if the patient has a abdominal wall scar, fibrotic tissue, so that the sonography rays are not effectively going inside. If the uterine size is too big, myoma size is more than 10 centimeter, or the patient requires further fertility, because if it destroys the fibroid, it will cause some damage to the uterus there. So if they want fertility, it is not a good modality. If it is a huge fibroid, this ultrasound would not work that beautifully. Now final surgical managements, we are heading towards it. 3 modalities: uterine artery embolization, myomectomy and hysterectomy. These are huge topics. I will be covering myomectomies and hysterectomies in different lectures to talk in detail about them. Myomectomy, as the name suggests, removal of the fibroid and taking it out. Hysterectomy, removing of the uterus altogether. Now I am talking about uterine artery embolization. This modality means what? From the femoral artery, if you remember our anatomy, from the femoral artery we proceed like this, go to our common iliac, go to the other side and then come down to the uterine artery of the contralateral side, and then we inject polyvinyl alcohol there. Polyvinyl alcohol will block the uterine artery. So from this side of the femoral artery you block this uterine artery, from this side you block this one. And since we block the uterine arteries, the blood supply of the tumor decreases and there is no blood, so the tumor decreases in size. Uterine arteries are occluded by injecting polyvinyl alcohol through percutaneous femoral artery catheterization. It causes avascular necrosis. The ultrasound was causes coagulative necrosis. It causes avascular because there is no vascularity, followed by shrinkage of the fibroid. Menorrhagia improves and there is reduction in the size of the fibroid. But yes, everything has its own side effects. There is something called as post-embolization syndrome, where the patient may develop pain, fever, sepsis, myometrial infarction and necrosis, amenorrhea, ovarian failure, everything because you are playing with the blood supply. So we should tell our patient everything about the pros and cons and then let the patient decide what she wants. With this, I conclude with the investigations and the treatment part of the fibroid, and the patient tailored management we will be talking about in our later classes. Thank you so much.